Hello, ladies and gentlemen. This is Jeyasuriyaa from Agam Medical College with a wonderful topic, the urinary bladder. This is the rapid war of this video. The urinary bladder, being a pelvic organ lying in the lesser pelvis in adult, is a muscular reservoir of urine with its mean capacity of about 220 milliliter, beyond which induces the desire to maturate and usually emptied at 250 to 300 milliliters. Beyond 500 milliliters of filling induces pain due to stretch of the receptors, and beyond 800 milliliter of the filling, the bladder loses the voluntary control of the hole to urine. And in children, the bladder is an abdominal pelvic organ with the neck lying above the pubic symphysis and descends to the pelvis on its enlargement at the age of 6 and becomes a pelvic organ, that is a proper pelvic organ, on a tiny puberty. So the bladder is ovoid in shape when filled completely and tetrahedral when it is empty. So basically, this is the sagittal section of the pelvic region of the male and the female cadaver subject towards the right and left respectively. Here you could see this is the pubic symphysis bone, and behind this lies the urinary bladder, and in front of the rectus lies this urinary bladder. This is the prostate gland. Somewhere here lies the prostate gland. So moving on to the female pelvis, this is the pubic symphysis, as you could see in the cadaveric image, and this is the urinary bladder lying behind the pubic symphysis and in front of the uterus in female, and behind the uterus lies the rectum. Now moving on to the external features, the apex, base, neck, the three surfaces, that is the superior and two infralateral surfaces, and four borders, that is the anterior, posterior and two lateral borders. Starting with the apex, lying behind the pubic symphysis, this is the apex. It attaches with the median umbilical ligament, which is a fibrous remnant of the Urecas. So basically this median umbilical ligament gets attached with the umbilicus and the apex, and it supports the bladder anterosuperiorly. Now moving on to the base or the fundus of the bladder, this is the base of the urinary bladder. Being triangular in shape, the upper part of the urinary bladder in male is separated from the rectum by the rectovesical pouch, which has coils of the small intestine. Whereas the lower part, this is the lower part of the base of the urinary bladder, this is the upper part of the base of the urinary bladder. In case of the lower part, it is separated from the rectum by the vas deferens and the seminal vesicles lying medially to laterally respectively. So basically this is the seminal vesicle, these are the seminal vesicles, and this is the terminal part of the vas deferens. The rectovesical fascia of 𝗵𝗵𝗶𝗃 separates the rectum from the triangular space between the vasa deferentia. So basically this is the triangular space that is divided by the rectovesical fascia of the 𝗵𝗵𝗶𝗃 from the rectum. Now moving on to the neck part of the urinary bladder. Here lies the neck part of the urinary bladder. It is at the junction of the infralateral and the posterior surfaces of the bladder where they meet up, and it is pierced by the urethra. In case of male subjects, it lies above the prostate, and its smooth muscles are continuous with the prostate gland. As you could see, it is continuous with the prostate gland. This is a male subject. And whereas in females, it is related to the urogenital diaphragm, as I mentioned earlier. It is related to the urogenital diaphragm. Now moving on to the superior surface, which is bounded by three borders, that is the posterior and two laterally bounded borders, where it joins the ureteric orifices, where the ureteric orifices, joints at the borders. Here you could see in the picture. In male, it is covered by the peritoneum. The superior surface is covered by the peritoneum, whereas in case of the female subjects, it is partially uncovered, and along the posterior border, where it is reflected on the supravaginal part of the uterine of the cervix. And somewhere here lies the 𝗵𝗲𝗂𝗃𝗃 pouch at this region, partially covering the uterus. Now moving on to the infralateral surface. This surface, as you could see in the picture, this is the infralateral surface. It is devoid of the peritoneum, and in both the male and the female subjects, it is related in front to the retropubic space of the 𝘊𝐺𝑠. This is the retropubic space of the 𝘊𝐺𝑠, as you can see in the cadaveric image. And the pubic symphysis in front. This is the pubic symphysis. So you can see this is the pubic symphysis and the 𝗵𝗶𝗴𝗀 ligaments that bind the urinary bladder with the anterior pelvic wall. And to the behind, by the obturator internus muscle above and the levator ani muscle below. Now moving on to the retropubic space of this 𝘊𝐺𝑠, as you could see in this picture, it is anteriorly bounded by the pubic symphysis and posteriorly that along the infralateral surface of the urinary bladder, and superiorly it extends up to the umbilicus on the reflection of the peritoneum that is covering the urinary bladder, and inferiorly it is bounded by the 𝗵𝗶𝗴𝗃 ligaments. Now moving on to the supports of the bladder. Prior to that, this is the retropubic space, as you could see in the picture, and these are the 𝗵𝗶𝗴𝗃 ligaments, and this is the pubic symphysis and the body of the pubis. Here lies the urinary bladder. Now with the supports of the bladder is basically anchored at the neck by the continuation of the prostate and the urethra. As you can see in the picture, the bladder is the continuation of the prostate. Here you could see the bladder's continuation of the prostate gland here in the male subject, and with the urethra, the membranous part, and along with that lies the penile part of the urethra. The other supports are by the ligaments that are classified into true and false ligaments, where the former is the condensation of the pelvic fascia around the neck and base of the bladder, and the latter do not provide any support to the bladder. Starting with the true ligaments, that is the lateral ligaments, 𝗵𝗶𝗴𝗃 ligaments, the median umbilical ligament, and the posterior ligament. The lateral ligaments are 2 in number. As you could see in the picture, this is the lateral ligament. It lies both along the left and the right side, and it extends from the infralateral surface of the bladder to the tendinous arch of the pelvic fascia, which lies along the abdominal wall. And the 𝗵𝗶𝗴𝗃 ligaments, they are 4 in number, 2 of each pair. That is the median 𝗵𝗶𝗴𝗃 ligament and the lateral 𝗵𝗶𝗴𝗃 ligament. These are the lateral 𝗵𝗶𝗴𝗃 ligament, and these are the median 𝗵𝗶𝗴𝗃 ligaments. Where the lateral 𝗵𝗶𝗴𝗃 ligament extends from the tendinous arch of the pelvic fascia along the wall of the pelvic cavity to blend with the upper part of the prostatic sheath. As you can see in this picture, it blends with the prostatic sheath. Now moving on to the medial 𝗵𝗶𝗴𝗃 ligament. This medial 𝗵𝗶𝗴𝗃 ligament extends from the pubic symphysis to the prostatic sheath and forms the floor of the retropubic space of 𝘊𝐺𝑠, as I mentioned earlier. On the other hand, the facial bands similar to the 𝗵𝗶𝗴𝗃 ligaments in the female are called as the 𝗵𝗶𝗴𝗃 ligaments, as they end around the neck of the urinary bladder in the female subjects. Now coming to the median umbilical ligament, which is the fibrous remnant of the Urecas, It extends from the apex of the bladder to the umbilicus, and it maintains the bladder in position both anteriorly and superiorly. As I mentioned earlier, this is the median umbilical ligament. Moving on to the posterior ligaments, these are the posterior ligaments. They are two in number on each side. They extend from the base of the bladder to the lateral pelvic wall and enclose the vesical venous plexus. Here you could see the vesical venous plexus is in the posterior ligament. Now moving on to the false ligaments. The false ligaments are 7 in number totally, and they are nothing but the folds of the peritoneum. Unlike the true ligaments, they hardly give any supportive function. Those are the anterior median umbilical fold and 2 medial umbilical folds, and laterally a pair of the false lateral ligaments that are formed by the reflection of the peritoneum from the bladder to the side wall of the pelvis, which is forming the floor of the paravesical fossa. And along the posterior aspect, the sacrogenital folds, a pair of sacrogenital folds which lie posteriorly on either side of the rectum to the anterior aspect of the third sacral vertebra, extending from the sides of the bladder. Now moving on to the microscopic structure or the histology of the urinary bladder, where for the simplicity we can classify this bladder wall into a mucous membrane and a muscular coat and the adventitia, where this mucous membrane has the urothelium or the transitional epithelium, as you could see in the histological diagram. This is the transitional epithelium with the umbrella shaped cells. On the other hand, this mucosal area that is covering the internal surface of the base of the bladder is termed as trigone of the bladder, which I'll mention in the later part. Moving on to the muscular coat. The muscular coat is generally termed as the detrusor muscle, which continues as 3 layers of smooth muscle fibers, the inner and outer longitudinal fibers and the middle circular fibers. Since the muscle fibers of the bladder wall are mainly concerned with the evacuation of the bladder, they are generally called as the detrusor muscle, as these 3 layers, that is the longitudinal and the circular layers, profusely intermingle, which cannot be separated into 3 distinct layers of the muscles. And the other part, these are the muscular layers: the inner longitudinal, the outer, the middle circular, and the outer longitudinal layers. As you can see in the picture, this is the outer longitudinal layer, and this is the lowermost is the adventitial layer, or the serosal layer, which is a fibroelastic tissue. Now moving to the interior of the bladder, where a prominently irregular folds which has a loose attachment to the sub-adjacent muscular layer. Hence, these are called as the rugae. But over a small triangular area immediately above and behind the internal orifice of the urethra, that is the trigone of the bladder, this mucous membrane is firmly adhered or bound to this mucous coat, and it is smooth enough where the boundaries of this layer or the trigone, as you could see, this is the trigone of the bladder. It is superiorly bounded by the ureteric opening and inferiorly bounded by the urethra. As you could see in the picture, these are the rugae, that is this innermost mucous membranous layer is loosely adherent to the muscular layer, whereas it is different from the trigone part. Now this trigone of this urinary bladder, as you could see in the cadaveric picture, This shows or presents a handful of features, something like the 𝗹𝗶𝗴𝗂𝗃, intra-ureteric ridge, or the bar of the Mercier, or the Bell's bar. So basically this trigone has got three angles, that is the antero-inferior angle, as you could see in the cadaveric image. This is the antero-inferior angle, and the posterior-superior angle formed by the urethra and the ureteric orifices respectively. On the other hand, the 𝗹𝗶𝗴𝗂𝗃, as you could see in this diagram, the 𝗹𝗶𝗴𝗂𝗃 is the elevation of the mucous membrane behind the internal ureteric orifice. This is the internal ureteric orifice. Behind this, there is an elevation named as 𝗹𝗶𝗴𝗂𝗃. So basically, this is produced by the median lobe of the prostate gland. Moving on to the interureteric ridge or crest or bar of the Mercier. This is the bar of the Mercier or the interureteric ridge. These are nothing but the superior boundary of the trigone of the bladder and the connection between the ureteric orifices, which produces a continuation into the bladder wall of the inner longitudinal coats of the ureters. So basically that is the continuation of the inner longitudinal coats of the ureters. On the other hand, along the lateral ends of this ridge, beyond the openings of the ureter or the ureteric folds, lies the ureteric folds which are produced by the ureters by running obliquely through the urinary bladder's wall. Now moving on to the Bell's bar, it extends from the ureteric orifice to the urethral orifice. This is the Bell's bar, as you can see in the diagram. So basically this is formed by or produced by the longitudinal fibers of the ureter that extends behind the ureteric orifice down on each side, as you can see in the picture of the trigone towards the middle lobe of the prostate gland. Now moving on to the vasculature of the urinary bladder, which is primarily derived from the internal iliac vessels, that is from the anterior division of the internal iliac vessels, where the arterial supply is via the superior vesical branch of the internal iliac artery, and in males this is supplemented by the inferior vesical artery, and in females by the vaginal arteries. In both the sexes, the obturator and the inferior gluteal arteries also contribute small branches. Now moving on to the venous drainage, as you could see in the picture, this is the anterior division of the internal iliac artery giving rise to the superior vesical artery. And on the other hand, moving on to the venous drainage, which is achieved by the vesical venous plexus, which empties into the internal iliac veins, and whereas the vesical plexus in male is continuous at the retropubic space with the prostatic venous plexus, that is something called as the plexus of the Santorini, which also receives blood from the dorsal vein of the penis. Now moving on to the innervation or the nerve supply, whereas the neurological control is quite complex, but for the simplicity it is classified into the sympathetic, parasympathetic and the somatic groups. So basically the parasympathetic fibers are also called as nervi urgentis, which are derived from the spinal micturition center, that is the S2, S3 and S4 segments of the spinal cord. They are the motor branches to the detrusor muscle and inhibitory to the sphincter vesicae, that is the internal urethral sphincter. On the other hand, the sympathetic fibers are derived from the T11, T12 thoracic and L1, L2 lumbar segments of the spinal cord, whereas these sympathetic fibers are inhibitory to this detrusor muscle and motor to the sphincter vesicae. On the other hand, moving on to the somatic fibers, that is the pudendal nerve. As you can see in the picture, it also lies along with the spinal micturition center, where the somatic fibers are derived from the S2, S3 and S4 spinal segments, and they are motor to the external urethric sphincter, where the sympathetic innervation is responsible for the filling of the bladder and parasympathetic innervation is responsible for the emptying of the bladder. On the other hand, the somatic innervation is responsible for the voluntary control of the micturition. So basically there are two kinds of fibers that can be seen. The first class is of the fibers concerned with the pain, and the other group of fibers that are concerned with the awareness or the filling of the bladder, where the pain fibers run in the anterolateral white columns of the spinal cord. On the other hand, the fibers concerned with the awareness of the filling of the bladder lie in the posterior column of the spinal cord. So basically the emptying of the bladder occurs due to the contraction of the detrusor muscle and the reciprocal relaxation of the internal and the external urethral sphincters, whereas the micturition reflex is integrated at the level of the spinal cord in case of the infants or the children, and at the level of the brain in case of the adults. As you could see in the picture, once the bladder exceeds 220 milliliter of filling and there is denial for the micturition, that creates the reflex contractions in the detrusor muscle, which become more and more powerful due to the increasing amount of the urine in the bladder. On the other hand, the stretch receptors in the bladder get stimulated and conduct the impulses towards the sacral segment, that is the spinal micturition center, by the spinal nerves S2 to S4. On synapsing with the preganglionic parasympathetic motor neurons, the stimuli pass through the parasympathetic nerves again back to the bladder as the efferent fibers, which relax the internal and the external urethral sphincters and the contraction of the smooth muscle of the detrusor muscle. So basically this leads to the micturition of the urine. But let's consider, whereas you are traveling in a bus or something like you're migrating from one place to the other, and you get an urge to micturate. But whereas during this part, the cortical or the paracentral lobule of the cerebral cortex or the cortical micturition center plays a key role by controlling the micturition, where it controls the spinal center of the micturition, stimulating the sympathetic fibers, which reciprocally contracts the internal and the external urethric sphincters. Now moving on to the lymphatic drainage, the lymphatics from the bladder mainly drain into the external iliac lymph nodes. As you could see, these are the external iliac lymph nodes. But whereas some of the lymphatic vessels also drain into the internal iliac lymph nodes, including the lymph nodes of the obturator fossa. As you could see, these are the internal iliac lymph nodes and these are the external iliac lymph nodes. Moving on to the developmental anatomy of the urinary bladder. Moving on to the congenital anomalies of the Urecas. These anomalies occur when the section, that is when a part of the Urecas does not seals off, but there is not a connection between the bladder and the umbilicus. So it can be classified into 3 or 4, like something like the patent Urecas, Uracil Sinus and the Diverticulum. Where in case of the patent Urecas, the Urecas did not seal off and there is a connection between the bladder and the umbilicus, and a patent Urecas can cause varying amounts of clear urine to leak at the umbilicus. Moving on to the Uracil Sinus, this occurs when the Urecas does not seal close to the umbilicus and leads to a blind ending tract from the umbilicus to the Urecas called as a sinus. So these can be asymptomatic or present with infection with the abdominal pain and drainage of the fluid. Moving to the diverticulum, This diverticulum occurs when the urachus did not seal or flows to the bladder and leads to a blind ending tract from the bladder into the urachus called as the diverticulum, and this also can be asymptomatic or present with a urinary tract infection. I think that's a wrap, and thank you. Good day.